Hello and welcome to our Cardiology module of Clinical Sciences. By the end of this module, you should be able to recognize the important structures and anatomical relations of the heart and understand basic physiological concepts of the cardiovascular system. Let's get started. The anatomy of the heart. We are going to discuss important points that are frequently tested in the examination. The right ventricle lies anterior to the left ventricle. The left atrium is the most posterior chamber of the heart. The right atrium is just anterior to the right of the left atrium. The left atrial appendage is not readily seen on transthoracic echocardiography and requires transesophageal echocardiography. The tricuspid valve is the most anterior valve of the heart and is the most common to be injured during a stabbing attack. Coronary arteries. Basic understanding of coronary anatomy is important as this is predictive of problems following myocardial infarction. Right coronary artery. The right coronary artery supplies the AV node, so heart block following inferior MI is common. The right coronary system also supplies the right ventricle, hence problems relating to a right ventricular infarct are commonly associated with an inferior MI. Right coronary artery supplies the inferior myocardium and occlusion causes ST elevation in leads 2, 3 and AVF. Posterior descending artery. It is a branch of the right coronary artery in 85% of people. In the remaining population, it is a branch of the circumflex artery. The concept of coronary dominance refers to which coronary artery supplies the posterior descending coronary artery. 85% of patients have a dominant right coronary artery and 15% of patients have a left dominant circumflex artery. This artery supplies the posterior left ventricular myocardium, hence occlusion causes posterior MI, which is seen on ECG by the presence of ST depression in V1 to V4 with the dominant R wave in V1. Left circumflex artery supplies the lateral aspect of the heart. Occlusion of this artery produces ST elevation in V5, V6, lead 1 and AVL. Left anterior descending artery. This artery supplies the anterior and the septal areas of the heart. Occlusion leads to ST segment elevation in leads V1 to V4. Left main stem. This branches into left anterior descending artery and circumflex and supplies most of the left ventricle. Complete left mainstem occlusion is invariably fatal. Occlusion produces extensive ST elevation across all chest leads, lead 1 and AVL and possibly AVR2. Cardiovascular physiology. The basic muscle unit of the myocardium is known as a sarcomere. The normal resting cell membrane potential of a cardiac myocyte is minus 90 millivolts. T-tubules and calcium channels. These are tubular networks formed by the invagination of the sarcolemma of the myocyte. Sarcolemmal calcium channels are located on the T-tubules. There are two main types of channels. The T channels that do not interact with conventional calcium channel blockers and the L-type channels which interact with calcium channel blockers. Left ventricular ejection fraction or LVEF. The left ventricle pumps blood in only a fraction of the blood it contains. The ejection fraction is the amount of the blood pumped, which is the stroke volume, divided by the amount of blood in the ventricle that contains. End diastolic volume. The ejection fraction hence is equivalent to the stroke volume divided by end diastolic volume multiplied by 100%. The stroke volume equals to end diastolic volume minus end systolic volume. Normal ejection fraction is more than 55% of the blood volume. Cardiac output. The cardiac output measures how much blood is ejected by the heart in 1 minute. Cardiac output equals to the stroke volume, which is the volume pumped in each beat times by the heart rate. Pulse pressure. This is the difference between the systolic and the diastolic pressure. Factors which increase pulse pressure include less compliant aorta, which is usually seen with advancing age, and increased stroke volume. Factors which reduce pulse pressure are high aortic compliance, reduced peripheral resistance, reduced venous return, and reduced stroke volume. This slide shows the cardiac action potential, which is what occurs at the membrane level. Phase 0 is the rapid depolarization phase where you see rapid sodium influx into the cell. These channels automatically deactivate after a few milliseconds. And it moves on to phase 1, which is the early depolarization phase, where you see efflux of potassium. Phase 2 is the plateau phase, where there is slow influx of calcium. Phase 3 is the final repolarization phase, where you notice efflux of potassium again. And lastly, phase 4 is the restoration of ionic concentration. This is the resting potential is restored by the sodium potassium ATPase. There is slow entry of sodium into the cell, decreasing the potential difference until the threshold potential is reached, triggering a new action potential. Jugular venous pressure. As well as providing information on right atrial pressure, the jugular vein waveform may provide clues to underlying valvular diseases. A wave, which is atrial contraction. Large A waves are seen in tricuspid stenosis, pulmonary stenosis, and pulmonary hypertension. It is absent in atrial fibrillation. Cannon A waves are caused by atrial contractions against a closed tricuspid valve. These are seen in complete heart block, ventricular tachycardia, ectopics, nodal rhythm, or single chamber ventricular pacing. C wave, which is the closure of the tricuspid valve. It is not normally visible. V wave. This happens in diastole due to the passive filling of blood into the atrium against a closed tricuspid valve. Giant V waves are seen in tricuspid regurgitation. X descent is the fall in atrial pressure during ventricular systole. And Y descent is seen in the opening of the tricuspid valve. Pulses. Pulsus paradoxus is greater than the normal fall in systolic pressure during inspiration. It's seen in severe asthma and cardiac tamponade. A slow rising pulse is seen in aortic stenosis, and a collapsing pulse is felt in aortic regurgitation, patent ductus arteriosus, and hyperkinetic conditions such as anemia, thyrotoxicosis, fever, exercise, or pregnancy. Pulsus alternans is a regular alternation of the force of the arterial pulse and seen in severe left ventricular failure associated with the third heart sound. Bispherians pulse is a double pulse with two systolic peaks. It's seen in mixed aortic valve disease. A jerky pulse is seen in hypertrophic obstructive cardiomyopathy. Heart sounds. The first heart sound, or S1, is caused by the closure of mitral and tricuspid valve. The causes of loud first heart sound are mitral stenosis, left to right shunts, a short PR interval with atrial premature beats, and hyperdynamic states. Causes of soft first heart sounds are mitral regurgitation and long PR interval. Second heart sound. It consists of the closure of the aortic valve followed by the closure of the pulmonary valve. Causes of a loud S2 are hypertension, hyperdynamic states, and atrial septal defect without pulmonary hypertension. Causes of a soft S2 as aortic stenosis. Cause of a fixed split second heart sound is seen in atrial septal defect. A widely split second heart sound is seen in right bundle branch block with heart failure, and right bundle branch block widens the split and the heart failure makes the split fixed. It is also seen in deep inspiration. Causes of a reversed split second heart sound, whereby you hear the P2 occurring before the A2, is seen in left bundle branch block, severe aortic stenosis, hypertrophic obstructive cardiomyopathy, right ventricular pacing, and patent ductus arteriosus. Third heart sound is caused by the diastolic filling of the ventricle. As soon as the mitral valve opens, blood rushes into the ventricle causing a splash sound, and it is heard in left ventricular failure, dilated cardiomyopathy, and constrictive pericarditis. The fourth heart sound is caused by the atrial contraction against a stiff ventricle. It is heard just before S1. Occurs with any type of left ventricular hypertrophy, which is caused by aortic stenosis, hypertension, or hypertrophic obstructive cardiomyopathy. Murmurs. Most murmurs of stenosis or regurgitation are exaggerated during squatting and gets softer with the Valsalva maneuver. The exceptions are in hypertrophic obstructive cardiomyopathy, where the opposite occurs, and mitral valve prolapse, where the murmur gets longer. This table in this slide will show the different murmurs and their respective causes. So let's look at the first type, which is ejection systolic murmur, which is seen in aortic stenosis, hypertrophic obstructive cardiomyopathy, pulmonary stenosis, atrial septal defect, and phallostetrology. A pansystolic murmur or holosystolic murmur is seen in mitral or tricuspid regurgitation, and ventricular septal defect, which is harsh in character. A late systolic murmur is seen in mitral valve prolapse and decoarctation of aorta. Early diastolic murmur is appreciated in aortic regurgitation, and a Graham-Steele murmur, which is a pulmonary regurgitation against a high-pitched and blowing in character. Mid-late diastolic murmur is seen in mitral stenosis. Austin Flint murmur is also a type of a mid-late diastolic murmur. It is caused by severe aortic regurgitation. It is rumbling in character. It is a low-frequency mid-late diastolic murmur which may show pre-systolic accentuation and is virtually indistinguishable from that of mitral stenosis. It is due to partial closure of the anterior leaflet of the mitral valve by the regurgitant jet. Continuous machine-like murmur, which is seen in patent ductus arteriosus. So this table summarizes the types of murmurs and their respective causes. We have come to the end of this topic. Thank you.